Hello, everybody. Good morning, good evening, good afternoon. What a day. Welcome to session 4 of day 2 of Rhythm Interventions Online 2021. I am Julian Chun, and working at the Markus Krankenhaus CCB team, Frankfurt, Germany. We have, after this tremendous live VT case, we have another very exciting case prepared for you. It's about left atrial appendage occlusion made simple. From Devi Nair, working in St. Bernard's Heart and Vascular Center, Jonesboro, Arkansas. Before we join them, let's meet our distinguished panel for this session. One of my fellow course co-directors, Jason Andrade, from Vancouver General Hospital, Luigi DiBiase, Montefiore Medical Center, New York, and Rodney Horton, St. David's Medical Center in Austin. And please remember all, we are live. Keep please submitting questions for the panel on the webpage throughout the session. We will address as many of them as we can. Without further delay, let's hand over to our live case operator, Devi. Devi, the stage is yours.
Hello, Julian. Can you hear me?
Excellent. We hear you. We see you. Hello.
Hello. Hi, Jason. Hi, Luigi. Hi, Rodney. Thank you for having us today. So we're going to have a live case for a left atrial appendage occlusion device. We are using the Watchman Flex device today. I want to start off by introducing my team. I have Janet here, who's my scrub. Have Joe from Boston Scientific, who's going to be supporting us. Roger is one of our CRNAs, and we've had a great team of CRNAs that help us with our imaging. So he's one of our team members. Anna is our echo tech and has been instrumental in our LAAC program. We have Heath, who's our monitor person, and Taylor is our circulating nurse. And Tia is our CRNA that is giving anesthesia. Now, we do our LA closure cases with general anesthesia because I just have a rock star CRNA team that have helped us keep this program going. And so they help us with our imaging, and they provide anesthesia for our patients as well. So without further ado, let me introduce the patient. We have an 81-year-old female that was referred to me for a possible LA closure implant. She has hypertension, she has diabetes, she's had CAD and stents, she's got a pacer, she's had an AF ablation in the past, and is currently maintaining sinus rhythm, has had multiple episodes of GI bleed requiring transfusion, and is currently on anticoagulation because obviously her CHA2DS2-VASc score is extremely high, and she has had significant concerns about staying on her Eliquis. She comes in today with uninterrupted anticoagulation, or partially interrupted. She has not taken her Eliquis this morning. She did it take last night, and that's kind of our routine practice for our LA closure implants. So in this patient, we actually have a CT. We don't always do a CT, but I'm getting into the habit of doing more and more CT pre-planning. So I want to kind of go over some of the CT images before we get into the case. So this is, we use the TruePlan software, which is proprietary to Boston Scientific, to kind of analyze the CT. And this kind of video kind of gives a general three-dimensional kind of aspect of that appendage, and gives you an idea of what direction the appendage is sitting in relationship to the other structures. Can I see that next slide, please? The beauty, obviously, is when you do a CT, you can do your measurements. The patient is euvolemic, so you get a much adequate measurement. And you can see where we have done our measurements there. Our maximum diameter that we actually saw on the CT was 21.9. We'll see more about the appendage a little bit later, but you can see where we did our analysis, and our mean is about 19, which I've put an arrow by the Watchman Flex device sizes, and it kind of overlaps somewhere in the 27 or a 31 millimeter device. It's on the I would say 31 if we see anything in the anatomy on TE that's more concerning, but a 27 or a 31 millimeter device. And I think that's one of the things I think about the Flex device, that there's so much overlap between the sizes that you might end up choosing between one or two of the devices. So let's look at the next slide, please. This is just a view that I usually implant. This is areocaudal view. So this is what I expect when I do a angio shot, and where I expect my transeptal to be most coaxial. Also tells me that I'm probably gonna be using a sheet that's gonna take me up into that anterior lobe, so mostly a double curve sheet. You can see the transeptal part. It's probably gonna have to be very inferior and probably more mid. So we'll aim for an inferior and mid transeptal. So that CT really kind of helps us pre-plan the procedure very well. Next slide, please. The software also gives you a simulation for the TEE, which I think is very advantageous if you are actually wanting to do procedures with ICE and are not as familiar with ICE-guided implants. Gives you a very good idea of what to expect in that TE image. And so I have all the 4 planes of 0, 90, 45, and 135 laid out there with the measurements where we did those measurements. And we'll look at the TE and see how close we came to this. Next slide, please. And you can also do kind of a sheet simulation as to how your sheet is going to sit. I routinely implant on a fluoro angle. I do an areocaudal, and on a TE, I keep it at 90. So I feel like that's most orthogonal for me. So I get 2 views of the appendage with my imaging in that way. Next slide, please. Yeah, so this is just looking at the 2 devices. On the left, I've superimposed a 27 device of how that would sit. And on the right, I went ahead and put a 31 in there to see how that would sit. You kind of get an idea of what the compression's going to be. You can see the 27 gives us a very kind of even compression. I like the shape of that device. But the question is going to be, what are those structures proximally? And if you do want to cover those, am I going to have to use a 31? The concern, obviously, is going to be an overcompressed Flex device, especially with a lot of compression distally within that appendage, which is definitely a concern for me. So we'll see how the TE looks, and so far with the 21.7 dimension, I think we're looking at maybe a 27 device. So really helps pre-plan, select the sheet, select where your transeptal needs to be, select the size of the device, and so really kind of streamlines the procedure very well if you have a CT prior. Let's look at the next slide. I want to just go over the sheet as well. Go ahead. So
amazing,
today,
the pictures
ahead,
and the
Julian.
simulation of planning your procedure. Maybe I take the chance by now and also make a quick round asking our distinguished panel, any thoughts regarding the pre-procedural plannings from your side? Would you do something differently, or what are your ideas on that? We start with Jason, and then we go to Luigi and Rodney.
Yeah, so I mean, for us, the LAA program, we have a multidisciplinary rounds where we typically do the imaging with TE and with CT, and then use that to plan the device selection and the sizing. So I've not personally seen the Boston Scientific proprietary software. We've just been doing it within our own imaging process, but for us, CT scan is a routine part of our program.
Luigi, what are your thoughts on that?
I can echo Jason's comment. We also routinely use the CT scan before to rule out, clot or to have ideas. If possible, we try to obtain this all the time. And I'm not familiar with the software of the Boston Scientific. For what I could see, it's very useful. I would say all these things are very useful when you're starting a program, where you're at the beginning. And of course, if you run into a workflow, everything is stable. But once you become familiar with the implant and you are an expert operator, I think the live information are the one that make you the most of the utility at the end of the day.
Yeah, so from my perspective, in our practice, most of the patients that come for appendage closure come from pretty far away. And so it's somewhat impractical to get a CT scan here locally, because we would probably be getting it the day before, giving them a large dye load, and then potentially giving them more contrast. Having CTs brought in from outside makes a bit more sense. We don't typically require pre-procedural imaging. However, Devi demonstrated just how powerful it can be. It was just spectacular to be able to see with just graphic detail that there was really two lobes to this device as opposed to one. In one angle, it looked like a standard windsock, but obviously it was sort of a cloved hoof. And you could also see this proximal pectinate area that you would sometimes miss on the lateral aspect, which is just abundantly clear here. So from a personality standpoint, I like surprises. So I kind of like to sort of be surprised on the table. But if you don't like surprises, this is just incredible what she demonstrated. This was fantastic.
All right,
So,
thank you.
And
So
I want
we're
to
heading
jump in
back
and say
to
that,
Arkansas,
yeah.
Devi. Yeah.
Yeah, so we don't always do CTs. I would love to, but it sometimes becomes impractical. But there's, as Rodney said, it's a very powerful tool when you have it. This was a True Plan, which is a proprietary software, but there are other softwares as well. Obviously there's Tremensio, there's FIOPS, there's a lot of other softwares that are coming in. So a lot of, I guess, workflow things that could be used. I also want to kind of go over the sheet. If we could go back to that slide. We're using the new sheet that comes with the Watchman. It's called the Watchman fixed curve sheet. On the top, I have it highlighted. So the difference between the older generation, which is the True Seal sheet, and the fixed curve is that the fixed curve comes in two sizes, two shapes. So there's a double curve and a single curve. So no more of that anterior curve. The double curve kind of takes over the anterior curve as well. The fixed curve sheet is actually more aligned for the Watchman Flex device, so it doesn't have all those three proximal marker bands. It just has one proximal marker band that's located at 10 millimeters from the distal marker end. So again, catered for the Watchman Flex device. Regarding the size, it's a little bit bigger. It's a 15 French outer diameter. Other than that, the seal and everything is the same. And that's what we are going to use. The sheet, I feel like, is also a little bit more, the braiding allows for a little bit more torqueability. So we'll see that. For transseptal, we're using a VersaCross system, and we'll demonstrate it as we go along. So we'll go ahead and start. We use ultrasound for our access for all vascular procedures here. So here we are starting with vascular ultrasound. And for the early users, I stick pretty medial to avoid any kind of arterial issues. And I feel like this one step kind of prevents any kind of vascular complication that you want to avoid in an elective procedure like this. Thank you. You can take that.
Yeah, I think this is a very nice demonstration of the importance of making this procedure super safe and also using ultrasound. Are you guys from the panel also using routinely ultrasound-guided puncture? Yes or no? No, we don't. We don't. For instance, we don't use it yet. But this is, of course,
Yes,
looks straightforward and.
Yes, always.
Yes.
I actually
Always?
lost the ability to feel arterial pulse on patients because I just put the probe and stick, and I have to say that I agree with many view. I mean, do you really need it?
Come up there for just
You don't really need it, but on big numbers, it makes a big difference. If you are a training program and you have fellows and you teach to use that, it makes a difference for sure. And on big numbers, it makes a difference. I would say I heard the same thing from transeptal. Many people say, "Oh, I don't need eyes. I
Debbie,
can do it without."
you drive the case. If you feel you want to continue, just go ahead and because the patient is on the table,
go ahead
of
and
course.
just show some of the stuff before. Yeah, if you don't mind. So I have the VersaCross system in my hand. So the dilator can be shaped. So I have the dilator in there. I'm going to shape it a little bit, and I want to show the VersaCross wire that I'm going to use. So this is an RF wire. I don't know whether you can zoom in on my hand here. So this is the tip of this wire is RF. So you can cross with the tip of the wire and push it out into this pigtail so it becomes a little atraumatic. I want to quickly share the TE images. We actually have TE in place. So if you can focus on the TE, that's a 0-degree angle. So Anna, go to the next one. So the measurements are a little bit smaller on TE. Obviously, the patient is NPO. So again, an advantage on CT where you get much better measurements. All right, so there's your 0, next one. There's your 45 degrees. You can see those, you don't really see those pectinate as much. Go ahead to the next one. You can see that pectinate very well, as Rodney was mentioning. There's some seriously proximal pectinates by the mitral side in this patient. Next. All right. Go ahead, next. We have a pretty decent velocity, but not the best. So we'll see. I think the patient does not have a lot of mechanical function in that left atrial appendage. Go ahead, next. This is the 135 view with a lot of proximal pectinates. Next, we'll do a biplane view. Yeah, there you go. Next one. All right, so this is where we are right now. I have the wire in the SVC. Let's go to the biplane view. So we are going to do our transeptal under TE guidance. I loved using ICE, but due to cutting down costs and stuff, we now do our transeptals and stuff with just TE. So I'm going up with the VersaCross sheath here. Can you optimize that just a little bit, Roger? There you go. So we have on our TE screen, the SVC is to the right side, the IVC is to the left side, just for orientation purposes. I'm coming in with the VersaCross transeptal system here. I'm going to go under fluoroscopy. I'm going to try to stay off of that lead if possible. I think I am in that lead right there. So, yeah. So I'm going to come down here and see if I can just kind of go medial to that lead early on so I don't pull that atrial lead down. So right there, I'll just kind of stop there. The tip of that needle is pretty radio-opaque as well. I'll take that first. Thank you. And the goal would be to do, we're going to try for an inferior and mid transeptal here. Definitely as inferior as possible with how anterior takeoff that appendage has.
Yeah, I think
so
it's
with the VersaCross system,
good idea to use the VersaCross here. The septum looks pretty small and also pretty enlarged as well. So I think it's a good idea. Yeah.
Yeah. I think I might still be kind of hung on that atrial lead, so I'm going to come off of that atrial lead there. Okay, so I'm pretty inferior there. Tenting on the, can you optimize that image? There you go. Explain that. So we're going to just run an explain through there to see how, so that's a little too posterior, so I'm going to come a little more mid there, come off there, right there. So that's still inferior and mid, which is where I want to go. So at this point, we're going to connect our RF needle and go ahead and RF, please. Okay, go ahead. So we just crossed across there, and we just crossed, and you can see on fluoroscopy we're going in. The one thing to keep in mind, let's go to the 45 angle. To keep in mind, this is, we're pretty coaxial to the appendage, so this wire is going to want to go into the appendage. Let's look at the appendage, please. So I always make sure before I move this versicross wire.
Devi.
Yeah, see how it's going into the appendage.
Yeah, beautiful, beautiful. But compared to your regular transeptals without the versicross, how much forces do you apply at the septum? Do you just push it as hard, or just let it go via the RF? Just a brief comment.
I usually I don't push at all. I barely have it touching. I do make the curve on the sheet to make sure I have a decent tenting. Together. Don't lose the transeptal. Push that transeptal.
Davey, any preference?
So
between, Davey, any preference between this type of looping wire versus the J wire?
So I've always used a pigtail wire. If I'm not using a versicross, I use a protract. I just like to not have to go into the pulmonary vein. I just loop it, and especially if you're doing eyes guided and stuff, it's more echogenic. I feel like this loop is much more echogenic than a regular J wire, but you could definitely use the J wire as well. So we're coming in with our double curve Watchman fixed curve sheet. You can see, before I cross, you can see the two markers. It's different than the regular true seal double curve. You can just see the two markers that are 10 millimeters apart. The sheath is more braided too, so you can see my pigtail wire, the versicross wire is in the pulmonary vein. And I'm going to cross at this point. The septum is thick, and I'm having to there you go. We just went across there. So one thing to always remember with the versicross is it will want to go into the appendage. So you really want to make sure that you're not pushing into the appendage. So we'll come out of there. All right. Go ahead, pigtail. So we're going to go in with the pigtail. If you guys want to take on for a second while I get that set up.
Yeah, beautiful. That was, I think, a very nice example how to super controlled get access into the left atrium and to make it. And this is obviously one of the also most important steps with regards to safety. Rodney, from your side, any thoughts?
Well,
to this case so far.
Yeah, so I'm a big fan of the versicross with the pigtail RF wire as Devi demonstrated it. I usually, once the sheath is in the left atrium, I'll never switch out to a plastic pigtail. I'll actually use the versicross pigtail in the appendage. The distal part is actually very atraumatic. The proximal end is actually quite rigid, so it gives you a bit more control and support for the sheath. Plus, it's a 24 millimeter size loop, so it gives you an exact metric to gauge angiographically on the size. So I think the puncture location and the orientation is such that you don't really require a whole lot of anything to get into the appendage. She did a fantastic job of locating the transeptal and positioning and selecting the sheath. So you probably could do it without anything, but I'm perfectly okay with using a plastic pigtail. But I guess my thought is, why even bother with it? I tend to just use the pigtail from the RF wire, which I find probably a little bit more helpful than a regular pigtail.
I totally agree. Sometimes we'll actually just load the pigtail on the versicross too, or you could just take the images with just the sheath. In this patient, I'm trying to minimize the contrast we give. So that's one of the reasons she had a CT as well. So we're going to actually do our injections through with the pigtail. Let's go to 45 so I can see the appendage better. All right, let me know when I get in. Should be in there. So we're going into the appendage with the pigtail. It's a very acute takeoff. Even though the VersaCross took me in there very well, the pigtail is definitely having a little bit of trouble getting in. So we'll see. It's getting in there. You can see on TE, I'm in there.
Yep.
Yeah, the pigtail's in there, but
so I might actually, I might actually use the VersaCross to get back in there.
Yeah, because the pigtail is not quite rigid enough to give you support to advance
it's not.
your feet.
So we might actually go back with
happening.
Let's get that. Yeah. So we will probably go back with the VersaCross to get back in. We'll give it one more try, and if it doesn't, we'll just cross it off.
And again,
in fact,
it's definitely not stiff enough.
So this was exactly the scenario that made me suddenly switch because I had exactly the same problem where sheath kept overwhelming the pigtail, and I switched out to the VersaCross pigtail wire, and it just held like a rail. Looks like I think you've got it now. But see how
I just got
flimsy the plastic is so flimsy. The pigtail can sometimes just get overwhelmed, and the VersaCross wire doesn't.
Yep. Agree.
Yeah,
so
very
we are
nice.
in. You can see the sheet. I don't really. Yeah, I mean, I if I didn't get in, I would have just put the pigtail wire back in, the VersaCross wire back in, because it's definitely stiffer and will get me in much easily. But we'll you can see my sheath is barely
Luigi
in.
He wants to make.
Yep, sure. Let's go ahead and take a shot.
Luigi, I thought you wanted to comment on that.
Yeah, I was just saying.
So then let's move on.
No, I was just saying, since she's doing this now, the good part is coming. I was just saying, how elegant and smooth is the transeptal by using, an RF needle and the wire. I mean, I'm sure you can do it without, but some septum are more thick, some position are more, you need to struggle in pushing more, pushing less, while it's a guided transeptal which makes things smooth and easy and very clean. So I think we need to think about this. Everything's possible without using these tools, but why you want to do things without it if we have them?
Yep. So you can see the angiogram. Let's play that. I'll play it. There you go. So you can definitely see the pectinate. This is definitely not a Vinsock. It looks more like a cauliflower, or Luigi, you can call it. You're the one that named all of these. I don't know. I'm measuring about 3 sheet sizes. It's a 15 French outer diameter sheet. So that's what I'm measuring here, about 3 sheet sizes at the ostium. What does the panel think for the size?
So in systolic, atrial systole is 3 sheath widths. Is probably a little bit bigger than that from that one particular obliquity. I'd probably call it more like 4 from that, at least at the widest angle. Because when the device goes in, it's not going to remain in a systolic, maximally contracted position. It will actually be held open. So it's more like the atrial diastolic dimension. So it's closer to 20 or even 21. It's highly contractile.
21, which we measured at, 21.7 is what we measured on CT. So we can, I guess we can. Would you prefer a 27 device, Rodney?
So this is an interesting question, and you had mentioned a 24. I mean, I think this is a perfect example where 2 sizes will actually work. But there's 2 things to at least consider when you're choosing the size. One, the obvious one is it how wide is it? And so do we have something that's going to be compressed when we put it into the appendage? But the other thing we actually have to consider in a case like this, because it's subtly complicated, is the length, because the bigger devices are a bit longer, particularly when they're a little bit more compressed. And we actually want a little bit more length because we have to be sure that we can cover that proximal pectinate portion. And if you put something in that's too short, one of two things will happen. Either you'll sit it right at the ostium, so it's perfectly positioned, but there's space behind it, distal to it. And if it's undercompressed and it's got space behind additional length, it sometimes can migrate distally later. After you've deployed it, it looks perfect, and then it ends up migrating distally because these anchors are intended to prevent it from coming back, not going forward. So I would personally lean a little bit more toward a 27 because I want the length from the 27.
Yep, that's what I was thinking.
Yeah, I agree.
I think.
So that was the thought process too, Ronnie. I'm very much concerned about a very distally compressed device with this hypercontractile appendage and with that much pectinate. So even the simulation kind of shows how the shape would be. So we're getting a 27 prep right now, so we'll let you guys kind of have your conversation.
Yeah, I personally think that
Luigi.
24 and 27 could be both okay, depending on where you release the device. So I agree with Rodney, probably to cover that part and we have some length, you can make the 27, but you need to go very distal. Or you can use a 24, but you need to have a perfect landing on the pectinate area. So probably the 27 offers more chances here to do both. But the 24
Jason,
be
what
okay.
are your thoughts on the sizing?
Yeah, I mean, I think if you told me you were going with a 24, I would probably try and talk you out of it because we get a lot of referrals for, I guess, what I describe as watchmen that behave badly. Because what happens acutely is one thing, but what happens chronically is another. And if they're undercompressed and because they're undercompressed, they're shorter and there's space behind it, they tend to just slowly migrate distally. And then they're not occluding, and then it's a big problem. And then they send them to me to try and fix that problem. And it's an avoidable problem. It's like I'd rather have the length of the slightly more compressed device to prevent that process from happening.
Yeah, I agree.
Thank you.
So we're going in with the 27
Jason,
device
any thoughts
right now.
from your side? Okay, so we
no,
decided
I mean,
27
Julian, I'm
and
gonna go in with
all
the
the
device.
pro and cons. Yeah, okay.
Sorry.
Good.
So we are going in with the device.
Comment
I have
from my
a
side.
good amount of counterclock on my sheet. Yeah.
Yeah, I think the counterclock is important because we have seen also very nicely in the CT imaging before that there are two lobes, and you want to make sure that you really get and dive into the anterior lobe to have also the amount of length and certain depth which is required. So yeah.
Yeah, you can see on TE, Julian, that I have explained the 135 angular sheath is looking nice and coaxial into that anterior lobe. And so I'm going to come in with the device. We are going to get up to the tip. Low tidal volumes, please. Because this is a contractile appendage, I'll just keep the volumes low.
Yeah, and go ahead and get to ball quickly. I don't want to distract you, but I would like you to comment on how the device straightens out or does not straighten out this new sheath, because it does behave a little different than the old sheath.
Yep, it does. Yeah, let me just finish this. So we're going to start deploying. So we're going to come into ball. And for me, the deployment is a very slow deployment. You can see the device is wanting to bend down. So I'm going to kind of take it counterclock, make sure it doesn't fall back on me. So I'm going to pull back a little bit to make sure I cover that. It's getting into that lobe there. I don't want it to get stuck in one lobe. So we'll deploy it right. So it went into one of the lobes. So I'm going to recapture it right away because I know I don't want to be there. Yeah, I don't want it there. So we'll come out of that, come back into that anterior lobe, and kind of deploy it. It's wanting to go into that posterior lobe again. So let me come out of that.
You might need to fully recapture
See if I can show me the ball.
The anchors may have remained engaged.
Yeah. So we're going to look on that TE and see if we can get into that anterior lobe more. It's still kind of looking more posterior there.
Yeah,
There was really no room for me to come. Go ahead.
Rodney is recommending the full recapture because maybe you have something engaged. So I think you should.
Sometimes the anchors are actually engaged even though they shouldn't be. So sometimes you have to fully recapture, and then suddenly now you can get back into a ball, and then there's nothing that you're anchored to. And then you can counterclockwise and get into that anterior
There you
lobe.
go.
Yep, there you go.
We look like we're more interior there. So
correct.
we're gonna go up there. I'm gonna stay there so it doesn't fall out and keep that counterclock on. It still is I'm a little bit concerned about what my pectinate are gonna look like. We'll see. I don't think I'll have coverage there. I think I'll have a leak there, the way this device is sitting. We can take a quick angio shot. Go ahead and fill it up. Have a feeling we'll probably have a leak there, so we'll probably have to pull back. All right, ready? Fill up. Okay, got it. There we go. Yeah, see that?
Oh, yep. See, there was one other
so we're going to come back.
There was one other issue with this anatomy that I meant to mention when you were showing the CT, and that was the takeoff. The ostium takes off really low. It's very caudal.
There.
And that's
Beautiful.
A deceptively complicated
that's much better.
case. Yep.
Yep. So this is the second. I recaptured from there, and I came to kind of the mid part and deployed it very austerely there. So
from this angle, it looks fantastic.
I'm going to take a shot here. Yep. So we'll take a shot here. Go ahead. So for me, that's a better implant. It covers all the lobes. It has good compression when I look at it on fluoroscopy. I think all the proximal pectinates look covered as well. We'll do color Doppler on our, I'm going to pull that sheet back just a little bit to kind of take that bias off.
And
you can see the amount of torque I have on that sheet.
Yeah, as Rodney was indicating, I think that one of the major problems was the very steep takeoff and the entry into this appendage. And you are now nicely covering this proximal part according to the angiogram. So this looks very good,
Yep, and on the TE as well, you can see that 90 showed us a lot of the proximal pectinates. You can see the device is sitting well. It's got that mushroom top, I guess. Rodney was talking about the sheath and how the sheath behaves as the device kind of gets loaded. So, with the TrueSeal sheath, it would actually raise that sheath up quite a bit. With this one, the sheath actually stays where it's supposed to. It doesn't have as much of a raise, so because it has so much more braiding in the sheath, that you don't get a lot of the sheath lifting up within the appendage as you load the Watchman system. Yeah, let's do an angio, and then I'm going to do a tug, okay? So I'm going to do a tug test, but the way I do my tug test is I actually do an angio, and with the Flex device, I think is not very radio opaque.
Before you show us your tug test, I would like to take the chance to ask our audience for the poll. Because you came up with a question before. So I would ask the audience, where do you see the value after this beautiful case of CT pre-planning in LAC procedures? Is it choosing the device type, device sizing? Is it avoiding TE and general anesthesia? Facilitating ice-guided implants? Improving procedural efficiency, or all of the above? Please vote.
Okay. Thanks, Julian, for putting the question up. So we're getting ready to do our angio. And so what we'll do is we'll do an angio and do the tug test with the angio in position. Okay. So you can actually see the device a little bit better. Ready? You can see the device is, the tug test is pretty stable. You can see that on TE as well. We'll do a 3D. And then we'll go through our pass criteria.
So one other thing to comment, and it's not as obvious with this injection as it was with the previous injection, but really the distal part of your appendage ended up right between the bifurcation of the anterior and posterior lobes. And that's exactly where your true plan had predicted you would place this. So it perfectly emulates what you were seeing on the software. Plus, what I like about that is this device has something that it is pushing against. So there's no way it could possibly migrate distally because it's hitting that septation between the anterior and posterior lobes.
That's good. Yeah.
It also is using every bit of that 27.
So Rodney, just out of curiosity, so if this had been a 24, you wouldn't have had the reach to hit that septation, right? And so then the argument would be that it may migrate out to one of those lobes.
My point was earlier was that it would by definition be less compressed. Of course, it'd probably be less than 10% compressed. Therefore, it would be a lot shorter. It would actually have 4 or 5 millimeters of space between the distal end of the device and that septation. And so there would really be nothing to prevent it from slowly migrating distally. And that is that's something we never saw with Watchman 2.5, but it is a phenomenon with the Flex. So we have to take it into consideration when we're choosing size.
Yeah.
Yeah, so this is a cranny shot. You can see there are no lobes that are uncovered. That's one of the things I focus on a lot, is to make sure I don't leave any uncovered lobes. Our 3D looked good as well. We are going to release the device since we have met the pass criteria, so we have a good position. We are within the appendage at the ostium. We have good anchors. Our tuck test is good. We have a good seal. We have good angiogram as well as on TE. We have good seal. And we have good compressions as well. On fluoroscopy, it looks like we have about 15% compression, and I think it comes down to 15% on our TE as well. So at this point, we're getting ready to release the device if the panel's okay with that.
I think it looks fantastic.
Looks very good. I think it looks, it's
okay.
Perfect job.
So we're going to counterclock on here, and we will release this device. And it's a stable release. So I always look for any device migration during release as well, especially since I had a good amount of torque. I did take the torque out before I did release the device. We do keep our ACTs at about 350, which is where we actually give our heparin pre-transeptal. So I forgot to mention that. And for our closure, we do a figure of 8. We actually do double figure of 8 sutures. If patients really want to have difficulty laying down for too long, or want to go home within 2 hours or something like that, then we'll actually do, we'll pre-close with the per-close. But obviously, that's a more expensive option. So we usually mostly do a double figure of 8. And the reason we do a double figure of 8 is it kind of helps with there's one, if you can focus on the groin here, I have one figure of 8 that's in there, and then the second figure of 8 that's a little more proximal and north of the other one. And that kind of helps prevent any kind of bleeding or oozing along the tract. So especially this patient that's under general, as they wake up, they start coughing. Usually with the single figure of 8, you might still need pressure, and you'll still need to hold the groin and stuff. But with the double, you actually don't have to do a lot of that stuff. And we use a stopcock instead of tying it down, because it helps us kind of mobilize the patient easily.
I have seen this last year. He already also did it, and it's a wonderful idea. So I know from other centers using that technique as well for closure. So this is a very practical tip. Debbie, there came one question up from the floor, which is asking, do you do procedural planning such as FIOPs?
So FIOPs is not available in the U.S. yet. So what I've been doing is I actually have been working, and I get my images that I've done so far, and we actually load those images after to see what the correlation is. And I've seen some excellent results. out of Europe. So I'm looking forward to having FIOPs come to the US so we can actually use it as well. But obviously, I have the TruePlan software for the Watchman devices, but especially when I use the Amulet device, I would definitely love to use the FIOP software for sure.
Yeah. And as a follow-up question, how much time, I mean, now you implanted in this pretty complex anatomy with that access, the appendage within, I think, 25 minutes or so. How much time do you invest in the pre-procedure planning compared to the procedure?
Yeah, so, I mean, I guess if you have pre-procedure planning, obviously, a lot of this, we had kind of planned on the 27. We knew what we were going in for. I knew what I needed to do transseptal. But again, as Luigi said, we started this program in 2016 and have been pretty busy with our LAC program. So it's not always that way. It does make it efficient in a sense that everybody in the lab already knows what we're going for. So from like a logistics standpoint, I think it's a great tool for us. If I have it, that's a great day. If I don't have it, I still get the case done without issues most of the time. But I think for a new operator and for a new center, I think it's a great tool because it takes a lot of pressure off of the operator, before the case itself. I just want to show this, what we have here in the groin here. We actually have a little bit of a D-stat patch. It's a C-LOX patch. It's just a thrombotic patch that kind of helps prevent any ooze from that skin nick. Patients, and it kind of gives a little bit of cushion for that stopcock. So helps prevent any kind of ooze. So the sheath is coming out. So the sheath is out. You can see we don't have any kind of bleeding or anything, and it looks good. So I've tightened that up. We're going to tighten the suture that's on the north end as well. And the advantage of this system for me is, so in about 3 hours, we'll let the patient, we'll loosen these stopcocks, let the patient ambulate. If they don't have any bleeding, they get to go home within 4 hours. If they have any kind of bleeding when they ambulate, I have them lay down and we tighten this back up. So we're not holding pressure or anything like that. So this kind of helps us. It's really very cost effective. But again, as I said, if we have patients that don't want to lay flat for 3 hours, have a back issue, something like that, we would actually pre-close them. And we'll do a double pre-close in that case.
Julian.
So we don't. We are taking our TE probe out. We don't have any effusion or anything. So that's one of the things we check. We make sure we don't have any effusion or any thrombus or anything. Everything looks good. So the TE probe is coming out now.
Julian, first of all, David, congratulations. You completed a case by the book. Very brilliant, difficult anatomy. Very congratulations. To go back to the comment we were making. I think, as we said, in a new program, it's important to do it. I think things have changed because this is a Watchman case. The Watchman flex have made the change. I mean, with the old Watchman, I think the pre-planning with CT was almost going to be mandatory because there were some anatomy where the Watchman 2.5 was actually not the best device for some anatomies. With the flex, I think that, it fits almost all the anatomy very well. So if you have it, if you are at the beginning, better to have it. If you don't have it, you can still do the case if you're an expert operator. So I think things are always relative to what you're doing, which device you're using.
Yeah, that's a very valid point.
Agree.
And of course, we in Europe, we have been in the lucky position for a couple of years to be or having also access to different devices with different designs, such as Amulet or the Lumbre, whatsoever. So in some labs also, of course, there is more freedom to decide right on the table for depending on the anatomy you encounter. But I also can say that was a beautiful case, and it was a fantastic demonstration how easy you can make, or you may look such a still complex procedure, and you made it look very, very straightforward and simple. So did I understand, Devi, you correctly? You have a regular daily base or the same-day discharge program also with LAC?
We actually do. This is something we actually were doing that even before COVID started, but obviously that's become almost full force since COVID, mostly because of bed situations and patients not wanting to stay in the hospital. But it's something that we implemented over time. It takes a team to make it happen. We have, the patients are scheduled in a manner that the ones that can go home are early in the day. And, we have patients that come to us from 100 miles away and don't want to go home the same day, or they don't have somebody at home with them, then I don't send them home. So there are certain criteria that we follow. But I would say 90% of our patients go home the same day with our AF ablations and with our LAAC program. Having said that, it's not, I'm extremely cautious of who goes home and who doesn't go home. And we change that. Even if we tell the patient that you can go home, if something in the case is concerning or if there is any issues post-procedure, we'll keep them overnight.
Well, yes, okay. It's super interesting because, in Europe here, on this side, we are way more conservative. We still have struggles, at least in Germany, thinking about same-day discharge after catheter ablation of AFib, for instance, or any ablation procedure. But for an LA closure, this is an even higher, I would say, barrier to let patients go home. And so you have not experienced, and this is my question, any, let's say, a slight delayed effusions, or you're not afraid of delayed dislodgement of the device?
I would say with the Flex device, the rate of late diffusions are really small. I think it's a pretty safe device. If there was anything during the case that was concerning, obviously, we will image, and we have a very low threshold for those patients. The amylin implants currently, we are doing an echo before they go home. Even our amylin implants are going home the same day. But if they have any concerns, we actually image them with a very low threshold, but not a whole lot. It really depends upon how the procedure went. So I kind of customize it based on how the case went.
Right. And with regards to the post-procedural care, what is your typical regimen for, let's say, follow-up visits with regards to TE control, your antithrombotic therapy? When do you take off? And so what are your criteria with regards to that?
So this patient, obviously, she's going to go home on her, she's on Eliquis. She was very particular that she did not want to be on any, she wanted to be on it as short time as possible, but we're going to try to do DOAC for 3 months. That's been our practice. I know per guidelines, it's 45 days and then DAT, but we've kind of switched over to just DOAC therapy for the first 3 months and then low-dose aspirin after that. We used to image at 45 days, but we've moved that out as well. We image a little more later at 3 months now, after the DOAC has been discontinued. In high-risk patients that are high risk for DRT, things of that sort, I will image even sooner. Like I'll image at 1 year. And sometimes even at 6 months if there's any concerns. And that imaging can be TE or CT. In this patient, it's usually a patient's choosing. I do prefer CT just because I think you get much clearer understanding of if you have a leak and the device position on CT. I think it does a good job. But if there are patients that don't want contrast, we'll actually do TE.
Yeah. I think the vote from the poll came back, and maybe we bring it up, the final result from the vote. So, okay, so the majority, or not the majority, but 50% of all the answers said that where do you see the value of CT pre-planning is basically choosing the device sizing with 20%, avoiding TE and GA, facilitating ICE, and improving procedure efficiency. So the 50% said overall meets the value of CT pre-planning. So you did apparently a very good job in convincing the audience to do this, to follow this path. Any thoughts from the panel?
Well, I think, yeah.
Well, maybe we'll
Go
go
ahead,
left
David.
to right. So I think it was an amazing case, Debbie. Congratulations. I think that it was very nice to see the link between how the CT predicted what we would see live during the case in terms of the TE, and also how the device would sit. And Rodney already pointed out how basically how accurate that CT prediction software was for the final position and what we ended up seeing. So it wasn't as straightforward a case, but it was very well done with an excellent end result. So congratulations on kind of giving us the full picture of it.
All of the
Thanks,
above, I
Jason.
think I agree. I mean, I think there is only 5% for the ICE because in Europe, not ICE is not used that much, but if you are using ICE only, having a CT may be very useful, and therefore, if you use ICE only, efficiency, they all come together. So for me, the answer is 50%, and the case that David showed clearly, showed the relevance of knowing it before about the lobes and the position.
Rodney, your final
Yeah, so
thoughts,
there's
remarks?
there's a lot to there's more to discuss than we really have time for with a lot of Debbie's comments. It's kind of interesting. So she images 3 months later, which clinically I totally agree with. It makes absolute sense. But the problem that we face, at least in the United States, is that there's the NCDR registry, and if you don't image within a certain approved time, you kind of get in trouble for it. So there's a little bit of a dilemma there, whether you image when the government tells you you're supposed to image, or whether you image when it's actually more appropriate clinically for the patient. So that's a challenge. And then one other comment was that we're all in the United States, we're all painfully aware of all of the fantastic and exciting devices that are available in Europe. We definitely have device envy.
Yeah. All right. Thank you. So, Debbie, you have 1 minute to share with us your final thoughts about this case, and yeah, go.
Well, I think, I hope we were able to show what, pre-planning can do for a case. And I think when you're starting to do left atrial appendage closure devices or doing them, I think it's all about understanding the three-dimensional anatomy of the appendage and choosing the right device that's going to actually give you the best effect. I think we have shown in multiple trials that the therapy is a good therapy in preventing stroke in patients who cannot take anticoagulation. And hopefully the new trials like Champion and Catalyst are going to give us more information on what the next set of patients, or if it could be a de novo therapy. And so that's yet to come. But I have to say that this is definitely not possible without having a great team, and I do have one of the best teams, I think. They have made us have a good LAAC program. So kudos to my team for keeping up with me and getting through this phase. I think we've gone through 5 years of this, so I have a fantastic team of CRNAs as well that help us do this on a regular basis. And again, for today, I have to say, got to give my AV team some credit because they were painfully with us through the whole thing. So Chris and his team from Atlanta did a great job, so thank you. Thank you to Julian and Rodney and Luigi and Jason. Thank you.
You did a tremendous job. Congratulations again. And I would like to thank you for showing this beautiful case together with your team. Thanks to our panelists, Jason, Luigi, and Rodney. And we are moving on to our next session, so stay tuned, and we will see you in a couple of seconds.